Alright, now that we have reviewed the changes made to the index and the tabular in the first part, let's get started on the code changes and additions relating to some commonly coded conditions. These are hypertension, coronary disease, Parkinson's disease, migraine, epilepsy, osteoporosis, signs and symptoms, sickle cell disease, appendicitis, and COVID screening. For easier navigation, you can find the timestamps in the description below for all these conditions. Hypertension. We have a new code to describe resistant hypertension, I1A0, falling under a brand new category, I1A. As per the newly added guideline, guideline 1C9A12, resistant hypertension refers to blood pressure of a patient with hypertension that remains above goal in spite of the use of antihypertensive medications. Assign code I1A0 resistant hypertension as an additional code when apparent treatment-resistant hypertension, or true resistant hypertension is documented by the provider. As a side note, resistant hypertension is diagnosed if the patient is already using 3 different antihypertensives from different pharmacological classes, but their blood pressure is still high. The guidelines continue. A code for the specific type of existing hypertension is sequenced first if known. Here we can see the same instruction in the tabular and an example for an elderly patient presenting to their provider with resistant primary hypertension. The coding would be I10 for the underlying hypertension, followed by I1A0 to specify that this hypertension is resistant to treatment. Next, coronary microvascular dysfunction. This is a new code to describe a form of ischemic heart disease where the coronary arteries are fine, but there is restriction in the microvasculature of the heart muscle. The microvasculature is the one that actually supplies the heart muscle with blood. Any disease there is a big problem. Manifestations of this condition can range from angina to heart failure and heart attack. As you can see from the index entry, we have new codes to describe these manifestations as well. Angina due to coronary microvascular disease codes to I2081 and has its own index entries like so. A heart attack due to coronary microvascular disease is coded as I21B. And notice the inclusion term under the code, myocardial infarction with non-obstructive coronary arteries with microvascular disease, or MINOCA. This is a good abbreviation to remember and look out for in the documentation. We have a new guideline related to this code as well, guideline IC9E6. It defines the condition as we have already done above, as the disease of the microvasculature of the heart, and specifies the applicable inclusion terms for code I21B. On to Parkinson's disease. Huge change from 2023 that instead of having only a single code to describe the condition, G20, now we have 5 new ones under 3 new subcategories. They will help to further specify whether the patient has dyskinesia and fluctuations or so-called off episodes. Let's clarify what these mean. Dyskinesia means difficult or involuntary movements. When associated with Parkinson's disease, this is not a sign of the disease, rather it is a side effect from Parkinson's disease drugs, most usually from levodopa. Fluctuations refer to motor fluctuations. This is the ability to control one's movement and muscle function. This happens because patients' drug levels keep fluctuating as time goes by, and when symptom control is good, the patient is said to be on, as in the drug is on and the patient is capable of normal functioning. The opposite of this is when the patient is off, or when their medication has worn off and the symptoms return. As you can see, it is very important to identify the exact type of Parkinsonism the patient suffers from to make sure that appropriate treatment can be provided. Besides the new codes, please notice that the default code has changed for both Parkinson's disease, not otherwise specified, and Parkinsonism, not otherwise specified. Until now, we would have coded G20 for everything, but from 2024, we have to assign G20A1 or G20C, depending on the provider's verbiage. Our next codes are also in the neurology section. For the next year, we have an entirely new subcategory for coding migraines, a very commonly seen diagnosis. G43E will describe chronic migraine with aura and has 4 new codes belonging to it. These new codes specify whether the patient's condition is intractable or not, and whether they have status migrainosus or not. For reference, chronic migraine is defined as having a headache on at least 15 days per month, with 8 of these having migraine symptoms for at least 3 months. This is not new, but relevant to the new codes, so worth mentioning. If you ever forget what verbiage qualifies to be coded as intractable, just reference the additional note under G43. Next, epilepsy. A new subcategory was created for Lafora progressive myoclonus epilepsy. The new codes fall under G40C for a total of 4 new codes. Again, the granularity of the codes serve the purpose of describing severity. And just like with migraines, if you need a reminder as to what counts as intractable, the applicable terms can be found under the main code G40. One important remark here, notice the code also instruction for this new subcategory. If need be, a dementia code will also have to be assigned in addition to G40C. This is not something that we are used to with epilepsy coding, so please take a mental note. Another important update happened to osteoporosis codes. We have 42 new codes to better define osteoporosis with pathological fractures. The reason for this change was that pelvic fractures could not be properly identified in the previous code set. They were categorized to osteoporosis of the thigh bone, the femur, what was anatomically incorrect. The new codes are M80B for age-related osteoporosis with pelvic fractures, and M88B for other osteoporotic pelvic fractures. As the inclusion terms show, other osteoporotic fractures happen due to drugs, post-surgical changes, trauma, or they are idiopathic, meaning that we really have no idea what is causing them. Let's see next the new codes in Chapter 18 for signs and symptoms. We will start with foreign body sensation. This is a new subcategory under R09 and contains 4 new codes to describe where the foreign body sensation is felt: unspecified, nose, throat, or other site. Also notice that the inclusion term of feeling of foreign body in throat was removed from under R0989 and was given its own code in the new subcategory R09A2. Here we can see what the new codes look like in the index. They are under index entry sensation foreign body. On a side note, this newly added index section also contains the new codes for foreign body sensation in the eye, codes starting with age 57-8A. Next, a new code for non-traumatic coma due to underlying condition. The code is R42A, and please note that its inclusion term is secondary coma. From 2024, we finally have a separate index entry and the code for secondary coma when associated with something else than traumatic brain injury. The related guideline was also updated to clarify that coma scale scores are not applicable to this new code. The reason is that coma scale elements are restricted to be used with traumatic brain injuries only. In summary, from now on, we have 3 main choices for coding coma: coma unspecified, R4020, traumatic coma with the combination of an injury code plus coma scale elements if known, and non-traumatic coma due to underlying conditions. Lastly, within Chapter 18, we have new codes to describe mammography results. Previously, we only had 1 code for dense breast tissue, but this was expanded into a new subcategory to be able to further specify what type of breast tissue was found on imaging. The types are defined by the BI-RADS or Breast Imaging Reporting and Data System and categorized into 4 groups: A, B, C, and D, or 1, 2, 3, 4. Type A for breasts consisting of almost entirely fatty tissue, B if there are scattered areas of fibroglandular tissue present, C for heterogeneously dense breasts, and D for extremely dense breasts. Our next topic is sickle cell disease. There were 3 changes made here. The first is the addition of new codes to specify dactylitis as a complication of the disease. Dactylitis is serious finger or toe swelling and pain affecting pediatric patients up to 6 years of age. Here are the new codes in the tabular and in the index D5704. It is of interest to note that having dactylitis is categorized as being in crisis, so the provider doesn't have to document crisis for us to capture this new code, saying dactylitis is enough. And this relates to the second change that was made to sickle cell coding. From now on, if the patient presents with SCD and is in pain, that is enough to code vaso-occlusive pain crisis. The term vaso-occlusive has become a non-essential modifier in the index and the tabular as well. This is significant because providers often just document sickle cell disease with pain, and they often omit the vaso-occlusive verbiage. Until now, it was always a problem whether we can code this or not, but from now on, if you see SCD, sickle cell disease, and pain, we can connect those in the index based on ICD-CM guideline 1A15. The last modification here is the addition of codes for sickle cell retinopathy. Up until now, we only had one code to describe any sort of retinal disorder in diseases classified elsewhere, but in the new code set, we have a whole new subcategory to further specify what's going on. H368 was created to describe either sickle cell retinopathy or everything else. With the caveat, of course, that we still have our excludes one note for arteriosclerotic and diabetic retinopathy. Those would not be coded here. The second to last change we have to look at happened to acute appendicitis coding. In 2023, we had two choices to describe acute appendicitis with peritonitis, the only difference being the presence or absence of an abscess. From 2024, we have 6 options because now we also have to specify whether the patient suffered a rupture or perforation. You see, in the previous code set, it was assumed that patients presenting with acute appendicitis and generalized peritonitis have suffered a perforation, hence the inclusion term under K35-2. But this is no longer the case in 2024. In the next year, we don't assume anything, we have to specify what happened. Finally, a quick note about COVID screening. Because the public health emergency ended, we are no longer to use Z2822 exposure to COVID for screening services. The correct code from now on is Z1152 encounter for screening. With that, we are done with the most important changes, but we still have more to go. So see you in the third and last part.